Okay, so a couple quick housekeeping things, and we'll turn it over to you later. This slide here just says everyone involved in these trainings has no financial relationships to the schools. Funding statement, we're a grant-funded project funded by the State Opioid Response Grant from SAMHSA. Those grant funds come down to us through the Nebraska Department of Health and Human Services. So we'd just like to acknowledge our partnership with Nebraska DHHS and thank them for helping us make these trainings possible. Okay, so everyone's going to get a 1 hour CME certificate for participating today. The way we do that is you just got to complete a quick evaluation survey. So I'm going to send that link out in an email, probably a couple hours after this training. I'll also drop that link in the chat too for you to grab it right at the end of the training. Just complete a quick survey, and then your CME certificate will pop right up. If you have any troubles, just shoot me an email and I can help with that. Slide is a bit funky today. So see a lot of repeat names, a lot of return participants here. For anyone who's new, this is Project Echo on substance use disorders and pain. So these are ongoing trainings. We do these 2 months on and then a month off. So we're back on here with a series of 4 trainings. This group of training is focused on substance use disorders, and I'll kind of go over what this current series looks like. We've got a hub team of 6 experts. We can do consultations during these trainings. There's usually time for questions or piece presentations at the end of every presentation. We've also done able to do these outside of these trainings, and the best way to do that is just to contact me, and I can put you in touch with one of our experts if you have a patient case you'd like to consult on, anything in the realm of patients with pain and or substance use disorders. Our experts are happy to help you all with that. So like I said, we do these in groups of 4. So this current series is focused on alcohol, cannabis, and methamphetamine use disorders. Here's our current lineup for this series of 4 trainings. And now I will let our hub team introduce themselves. We may be missing a couple of members, but I will let you start. Janet, do you want to introduce yourself?
Okay, yeah, I'm Janet Bernard. I'm a retired family physician from North Platte. Used Suboxone for opioid use disorder for years before I retired.
I guess I do see all of our hub team here. So Gail, would you like to go next?
Yeah, I'm Gail Teller. I'm a nurse practitioner down in Falls City, Nebraska.
John.
Hi, I'm John Massey, and I'm a pain physician here in Lincoln.
Stephanie.
Hi, I'm Stephanie Bennington. I'm a psychiatrist primarily located in Omaha.
Good morning, Todd Stull. I'm a psychiatrist as well, and happy to be here. And we're hoping to have a lot of input today. And please reach out to us if you have questions.
And Ed, I'll let you take it from here.
All right, thank you. Hey, good morning, everybody. Can you see that screen now, Will? Okay, perfect. Yeah, it's a pleasure to be with you guys. Ed Kaiser, I'm a nurse practitioner in Omaha, Nebraska. Have been working with substance use disorder for the last 6 years. And yeah, it's been a privilege to really be a part of these trainings. And we do want to just really make sure that you guys are aware that we are available to you to consult outside of these times. I've also even set up a couple times where we're doing some like shadowing opportunities. If people are interested in like seeing patients with opiate use disorder or substance use disorder, we can accommodate some of that stuff virtually as well. So today I get the opportunity to talk about alcohol use disorder. One of the things that I often ask my patients to do when I'm treating them is just to be as honest as they can with me. And so I tell them that my main goal in helping them is to help them accomplish their goals and to make sure that I'm keeping them safe in the process. In return, I also try to be as honest as I can with the patients that I'm treating. And so with that said, it's a little bit ironic to me that I'm doing a presentation on alcohol use disorder, because honestly, this has been one of the difficult patient populations, or maybe the most difficult patient populations that I've treated in the last 66 years. And quite frankly, I did not like treating this patient population initially. I started my career in the ER, and so I saw some patients like coming in to do detox there.
Oh my God, every
And then
day,
about 4 years ago,
day.
I think I'm getting a little bit of feedback. If you can mute your mics, that'd be great. Um, and then about 4 years ago, I was serving on a consult team with Ideal Option, and we started to like really specifically market to treat patients with alcohol use disorder. And so me and a group of other people were tasked with sort of learning how to do this really well and being available to other people to actually help assist when we were treating this in the outpatient setting. And and in my experience during that time, I just found that this patient population had a significantly high rate of return to substance use. When we were treating them in the outpatient, there was a lot of like labor intensive initial couple evaluations to like understand what was going on with them and get them set up on the right drug regimen. And then unfortunately, these patients either would stop coming back to us or they would have a return to use. And so again, not my most favorite population to treat. However, I was introduced to the Sinclair method about 4 years ago, and I didn't really use it a lot at that time. But within the last year, through a series of events, more specifically, a patient that was really just like gung ho on wanting to do the Sinclair method, had done it before, had worked really well for her, that I began to sort of do some more research on it. And since then, I've really become a proponent of at least educating patients on this method and making it available to them, and even really trying to push them to do it if they've tried other things in the past that haven't worked. And so I actually really enjoy treating this patient population now because the Sinclair method is super simple. So here's kind of the direction that we're going to go today. Again, honestly, I want to convince you to implement the Sinclair method into your practice to treat alcohol use. We're going to review a little bit of why alcohol is so addicting. We're going to talk about appropriately diagnosing alcohol use disorder. We'll talk a little bit about the detox process and sort of like the neuroadaptations that happen when people chronically use alcohol. And I will talk about other medications for alcohol use, and then we'll kind of find a finish today, spending some time on the Sinclair method. So let's look at some of the statistics first. Related to alcohol use. Again, this data is from 2020, 2021, but essentially at that time, excessive alcohol use was responsible for about 488 deaths per year, or 178,000 deaths in the United States. So sorry, 488 deaths per day. This was an increase from 2016 to 2017. And this third bullet point, it says that deaths from excessive drinking shortened the lives of those who died by an average of 24 years, for a total of about 4 million years of potential life lost. And so to me, that's really kind of a staggering number. 2/3 of the deaths that are associated with alcohol use are due to chronic conditions that develop. So when we think of like cancer, heart disease, liver disease, and other problems with alcohol use disorder. And then 1/3 of the deaths tend to be from sort of like drinking too much on one occasion. So motor vehicle crashes, poisonings, suicide, things like that. Here's another sort of slide for you on the data. And this compares alcohol use to opiate use disorder. So again, opiate use disorder gets a lot of money and funding and education and like it's media at this point. But when you compare the numbers, and again, this is from like 2020, alcohol use outpaces opiate use in misuse, diagnoses, emergency department visits, and deaths annually from in comparison. And so again, we see at the very bottom of this slide that when we talk about synthetic opiates, there's a high rate of death from that. But again, acute and chronic alcohol use is far above problematic wise. All right, so let's talk a little bit about why is alcohol so addicting. In this slide will be helpful as we kind of go through the training, but this is the sort of the mechanism by which alcohol intake is sort of positively reinforced in the brain. And initially, the alcohol gets broken down into acetaldehyde, which is the primary metabolite of alcohol, and it's thought to undergo further metabolism to structures that are similar to morphine that sort of bind to the opiate receptors in the brain, and then that kicks off this sort of dopamine release in the reward circuitry that we kind of talked about in the past. Alcohol also causes this release of this opiate endorphin, which activates the reward pathway as well in the opiate area. And then finally, it inhibits the NMDA receptor activation in certain areas of the brain, which increases the amount of dopamine circulating through the limbic system. So all of these mechanisms, as the alcohol breaks down, sort of reinforces in the brain this behavior, and it sort of carries this significant reward, especially for certain individuals who are more prone to it, and that this behavior should be repeated. All right, so when we first are evaluating patients, first we want to do kind of an alcohol assessment. And this slide is probably familiar to you guys. This is the CDC thresholds that indicate how much drinking is potentially hazardous. So we kind of do these screenings with patients, and generally, again, for men, it's greater than or equal to 5 standard drinks in a single sitting, greater than or equal to 15 in a week, and then for women, it's 4 and 8 respectively. One of the things that I think patients often sort of miss in their alcohol use, as far as like trying to be honest about how much alcohol they're using, is sort of the second one here, where it's kind of a 7% alcohol. A lot of times there's these new beers, these IPAs, or higher content alcohol drinks that you may get at a bar or something like that. And so if you have a 12 ounce of a 7% or an 8%, you're really having like up to a drink and a half at a time. And so really trying to accurately gauge how much people are drinking. This can be one of the initial tools that we do. Anytime I do a training, oh, sorry, that's the next one. So the audit C score, this is another one where it's just an easy, quick, simple scoring test. Talks about how often you're having a drink, how many drinks you're having at a time, and then how often are you having 6 or more drinks on one occasion. And so this is just for like risky or hazardous drinking behavior. The only note on the audit C score that I think is relevant is like if all of the points are from the first one. So if somebody's having a drink 4 or more times a week, but they're 1 or 2 drinks, or they're never having more than 6, then that would sort of maybe be outside of the scoring where they're having risky behavior. And this is the slide I started to talk about last time. So this is the DSM-5 criteria for alcohol use. I'm always talking about this sort of diagnosis of either alcohol or opiate use disorder. But again, the questions are pretty straightforward. Is it used in a larger amount of time than or longer than was intended? Have you had unsuccessful efforts or desire to cut back or control the alcohol use? Excessive amount of time spending obtaining or using it, craving, strong desire, then social components of it, failure to fulfill major roles at work, school, or home, social or interpersonal problems, giving up, things that you enjoy to do, physically hazardous use of alcohol. A lot of times drinking and driving obviously falls into that. And then any physical or psychological problems. And then the final one is sort of the tolerance and needing more to get the desired effect, and or going into withdrawals when you stop drinking. And so as you can see the scoring at the bottom, really you just have to answer yes to a couple of these to get a mild score. A lot of the patients that I'm seeing are definitely in the moderate to severe range of the diagnosis criteria. Another initial thing that I do when I'm treating patients with alcohol use disorders, I always ask them like, hey, what is your goal in this evaluation today? What are you hoping to do? And so usually falls into 2 main categories. One is just, hey, I want to stop all of my alcohol use and I never want to drink again. The other one is, hey, I just want to reduce my alcohol use. I want to try to cut back on it and maybe control it so it's not causing problems, in my life. And again, the goals of what the patient may set at the initial thing may change throughout treatment, so we do want to kind of revisit them. And then I always like to just really confirm that the goals are the actual patient goals and not the family goals. A lot of times patients will be sort of brought in or encouraged to come in because of family members or their spouse. And when I get them sort of one-on-one and ask them the questions, they're more saying to me, hey, I'd rather cut back and it not cause problems versus, my wife or my family wants me to be fully done with this. So this is a good, important part. And then when I think about alcohol use disorder, there's sort of 2 main components of treating alcohol use disorder. If you're thinking about a patient that has a goal of abstinence. So The first component is sort of this detox phase, generally happens within the first week. A lot of times patients need to go to a detox facility or to the ER. There's places in Omaha and Lincoln where you can go to, like, state funded detox places. Douglas County Detox does a really good job. And then what I was referring to earlier, we have prescribed medications at home for patients to go through the detox process as well. After there's that component in the abstinence model, the second part is, relapse prevention. So medication management, counseling, AA. Again, the standard of care for alcohol is always detox followed by medication support for alcohol relapse when we're trying to treat patients with alcohol use disorder. All right, we're transitioning to the sort of the neuroadaptations that are going to happen with chronic alcohol use. So understanding alcohol withdrawal requires sort of just a quick review of the receptors in the brain and the effects that alcohol has on those receptors. So there's two kind of primary players involved in alcohol withdrawal, which is the GABA receptors and the NMDA receptors. The GABA receptor, again, is the primary inhibitory receptor of the central nervous system, meaning that its activation causes this inhibitory effect, which includes sort of anti-anxiety, anti-convulsant, sort of muscle relaxer effects. And then again, the primary neurotransmitter that acts upon this receptor is GABA, so it's considered kind of the primary inhibitory transmitter. Again, sedating medications like Z drugs, barbiturates, alcohol sort of exert their effects binding to different sites on this GABA receptor and again, enhancing the inhibitory effects of those receptors. So conversely, or on the other side, it's the NMDA receptor that is the primary excitatory receptor in the central nervous system, meaning that its activation causes the excitatory effects. And the glutamine is the primary neurotransmitter that activates on that. So the diagram sort of at the bottom right of this slide sort of shows us like normal brain function, right? So GABA and MDR, every time the brain wants to be sort of a homeostasis and everything is good. When we have an alcohol or acute alcohol exposure, it increases the inhibitory effects of those mechanisms, and essentially you get sort of the normal manifestations that would happen with acute alcohol. So imbalance in this, sort of like teeter-totter thing causes CNS depression, sedation, and because of the increase in the GABA and the decrease in the NMDR. So again, if someone chronically is sort of in this state where they have chronic exposure to alcohol, the imbalance, the brain begins to want to get back to what we would know as just sort of like a homeostasis state. And so the adaptations to chronic alcohol use are sort of described here in this slide, where we increase the sensitivity of the NMDR receptors in the central nervous system, and also we downregulate the GABA receptors. And again, the brain is sort of is planning on getting alcohol on a regular basis, and we get this new balance that sort of gets this to what is a homeostasis. So when alcohol is removed from the system, we get this unopposed sort of excess of this glutamine activity, and it tips this, this balance in the wrong direction, and we get this excessive excitatory overact and hyperactivity of the sympathetic nervous system. And that's where we get sort of the typical symptoms of alcohol withdrawal symptom. And those symptoms can sort of be summarized in this slide right here. Again, you can sort of read through this. The symptoms of alcohol withdrawal sort of are characteristics, but it is important to keep in mind that the progression of alcohol withdrawal is not necessarily linear, and it may present differently depending on patient-specific experiences. And generally, it'll go for about 5 to 7 days. So again, the last stage of the withdrawal symptom is the delirium tremors, which is confusion, electrolyte imbalances, hemodynamic instability. And untreated DTs does have a mortality rate of about 40%, where if we are treating them and if people have timely intervention, the mortality rate is less than 5%. When you're asking patients about their history of withdrawals, of what they've gone through before, it is really important to sort of distinguish a true delirium tremor from just the tremor that the patients get sort of early on in their alcohol withdrawal. You'll see their hands sort of shaking like that. Many patients oftentimes will say, oh yeah, I've had DTs after a few hours without alcohol. But again, generally patients who have experienced true DTs are going to be managed in the inpatient setting in the ICU. And again, just clarifying that can be helpful as we try to think about patients' prior withdrawal symptoms. One of the other things that is helpful to remember when you think about alcohol withdrawal is sort of this alcohol sensitization or the kindling effect that can happen. And essentially what this is this phenomenon where the severity and intensity of alcohol withdrawal signs and symptoms will increase with repeated episodes of withdrawals. So patients with history of severe withdrawals have a higher risk of recurrent subsequent episodes of withdrawal. And so when we were like treating patients in the outpatient setting for alcohol withdrawal syndrome, if they've had severe DTs in the past or they've been hospitalized, a lot of times we would really encourage those patients to go to the inpatient setting to be treated because of the risk. All right, so we've kind of talked about why alcohol is so addicting, appropriately diagnosing alcohol, sort of the detox neuroadaptations. Now I want to spend a little bit of time just sort of going over the different medications that are used for alcohol use disorder. So here's a nice little slide that sort of compares most of the medications that we use for alcohol use disorder. I'm going to sort of, as we go through this, we'll go into each one in more depth, but it kind of goes through FDA approvals. Some of the medications are not approved by the FDA, kind of how the medication works, what it's targeted to do, if there's abuse potential with the medication, if you have to be abstinent at the time of initiating the medication, and then what medications it can be safe with as far as with alcohol. And then again, at the bottom of the slide, you know, pregnancy and breastfeeding, generally not recommended, contraindicated with some of them, but obviously patients who are pregnant should not be using any alcohol. So I'm going to start with acamprosate or Camprol. The mechanism is unknown, kind of goes over the dosing here. Again, this slide is probably best as just sort of a reference model. I want to go to the second slide about acamprosate and talk about the pros and cons. So pros of this medication, it's effective option for treating relapse prevention. It is considered a first-line option for patients who have a contraindication to naltrexone. And again, we're going to talk about naltrexone a lot more here with the Sinclair method. It can be taken concurrently with opiates, including buprenorphine. And so again, the patient populations that I see obviously are, you know, on buprenorphine or have a history of opiate use. And so I will often use acamprosate to add that to their regimen if they are having trouble with alcohol as well. One of the cons, you know, acamprosate is dosed 3 times a day, so that can be difficult for patients to remember to do appropriately. It does require abstinence from alcohol prior to initiating the treatment to be as effective. It is not effective for reducing heavy drinking. And then one of the side effects that is really prominent and oftentimes patients will stop taking acamprosate for is because of the diarrhea that can be associated with that medication. All right, so here's a quick look at, you know, disulfiram or antabuse. Honestly, when patients come in, especially when their family members come in, I think this is sort of what people generally just go to in their brain of like, hey, why don't we just give people antabuse, right? Stop drinking for a couple of days, take this medication every day. And if somebody drinks alcohol while on the antabuse, it's going to make them super sick. And so this is how we should treat, you know, patients with alcohol use disorder. Again, this can be a medication that is effective for relapse prevention. You can initiate the treatment. It's the wrong slide. There we go. May be effective for highly motivated patients. So the antabuse, again, for patients that are really highly motivated and otherwise unable to abstain from alcohol, this can be a good one. This is not considered a first-line agent for alcohol use disorder, more of a second-line agent. It usually is ineffective if it's not taken under supervision, so either a family member or somebody else that's helping patients. There is actually kind of limited data on the efficacy of it. And then this sort of disulfiram ethanol reaction, which we won't go into detail exactly how that happens, but it really actually can be kind of dangerous in certain patient populations if they do drink on the medication. So it is an option. I do use it sometimes, but definitely not first line. All right, so here's a quick look at topiramate. We'll go to the pros and cons slide on this one. Again, topiramate or Topamax can be effective for relapse prevention. You can initiate this treatment during active alcohol use to reduce heavy drinking. So that's a really good thing if patients are heavy drinking. Can be used concurrently with opiates. So again, a lot of my patient populations that has the buprenorphine on board. The cons of topiramate, it is not an FDA-approved medication for alcohol use disorder. It does have some sort of limited long-term efficacy data, and it does require a slow titration up on the medication as well as down on the medication if you decide to discontinue it. Not as great on the side effects, and it does have some potentials for drug-drug interactions. If you decide to use topiramate, here's sort of the list of the drug-drug interactions that can be sort of common with that medication. And then here's a slide on gabapentin. Again, let's kind of jump forward to the pros and cons. I think this is a reasonable option for patients who have failed first-line agents. And then oftentimes in the outpatient setting, we will use gabapentin to detox patients over the first 3 or 4 days if their withdrawals are not severe. And so it could be an option to continue if patients have successfully detoxed off of alcohol in the ambulatory setting. Often it can help patients with their mood and their sleep. Again, the cons of this medication for alcohol use disorder is not really FDA approved. Limited long-term efficacy data, can be sedating, especially if patients continue to drink alcohol while taking the gabapentin. There is a risk of dependence on gabapentin. And then, yeah, like I mentioned before, oversedation when combining this with other CNS depressants. All right, let's talk about the naltrexone now. So the way that the naltrexone works is it blocks the endorphin release during alcohol consumption, binding to the opiate receptor. It reduces this euphoric effect when alcohol is consumed, and it sort of reduces cravings. Comes in both a pill form as well as an injectable form. And again, there's 2 options here for using naltrexone. One is just daily dosing of the medication or Vivitrol. The other option, which we're about to talk a lot more about, is the Sinclair method. And this is sort of this ongoing alcohol use while taking naltrexone an hour before drinking. There are some contraindications about hepatic failure. Obviously, you cannot use naltrexone with opiate use or buprenorphine. So you do have to be mindful of that. I threw this slide back in there because I just wanted you to reiterate sort of where the naltrexone is working. So when we go to this breakdown of alcohol to the morphine components, again, the naltrexone is blocking all of that morphine, dopamine, endorphins, and that's how the medication sort of helps block that. Pros and cons on the naltrexone, again, believed to be the gold standard for alcohol relapse prevention. You can initiate this treatment during active drinking. Preferable dosing schedule, generally well tolerated, few drug-drug interactions, and it does reduce cravings. The cons of it, you cannot use it during opiate use disorder, including buprenorphine. Does need some liver function testing that we'll talk about again more, and the Vivitrol can be a little bit expensive. All right, so I've done all of this work on the front end to talk about alcohol, why it's addicting, alcohol use disorder, neuroadaptations, medications that are certainly available. And now if you've like tuned out for the first half of this presentation, dial back in with me for a second. We're finally going to talk about the Sinclair method, okay? So the rest of this slide is sort of, slide deck is based on the Sinclair method. Here's a book about the Sinclair method written by Roy Escape. And so a lot of the reference material is going to come from here, although there is a lot of research around it. So what exactly is the Sinclair method? Essentially what it is it's a medically proven way to eliminate alcohol addiction. One of the most relevant studies that was done on the Sinclair method was this Project Combine, which was done in 2006 and published in the Journal of American Medical Association. I'll go into that details of that study here in a little bit. There's been multiple clinical trials that have confirmed the success of the Sinclair method. And the Sinclair method claims that it has success rates that are upwards of 78%, where most of the rehabilitation rates for treating alcohol use disorder are relatively low, around 10 or 15%. So what the Sinclair method is, I sort of referenced it briefly earlier, but essentially what patients do is they take 50 milligrams of naltrexone 1 hour prior to taking their first drink of alcohol. And essentially the formula is this: naltrexone plus drinking alcohol equals a cure for alcohol in the long run. And again, patients are able to drink alcohol during this process, and sort of over the course of 3 to 6 months, what happens is they regain control of their alcohol use. And at that point, patients do one of two things. They may continue to drink at a safe rate, or patients, if they really do want to stop using alcohol at that point, are able to sort of do that on their own. So how does this sort of Sinclair method work? It's based on these three concepts, and I'll kind of go into these concepts in more detail. But the first concept is this alcohol deprivation effect. And what this does is sort of explain how abstinence from alcohol leads to this sort of increasing cravings and desire to use alcohol, where patients are able to do this for a period of time, but eventually the cravings get so high that they end up returning to alcohol use and then generally back to their normal drinking patterns. The second concept is this pharmacological extinction, where this is Sinclair's sort of method for removing the alcohol addiction. And then the third component of the Sinclair method is this pharmacologically enhanced learning, where what we're trying to do in this part of the treatment is to help patients strengthen sort of alternative behaviors outside of their alcohol use. So the alcohol deprivation effect is one of the most studied effects in alcohol research, and it's believed to sort of be one of the main causes of substance use sort of being a long-term disease process or a lifelong problem. And so a lot of times when we talk about substance use disorder now, we speak of it as a chronic disease, long-term process where patients are going to deal with this, oftentimes for their whole life. They may need to be on a medication their whole life, like Suboxone. The concept of this is that when an individual has a pattern of drinking followed by abstinence, that the craving and desire to increases until the use is resumed. So whether people do this in treatment or they go to jail, whatever happens, they sort of have this abstinence period, but as soon as they go back to alcohol, they return to their a little bit higher and then back to baseline. This is sort of the concept that AA is set up on. And if you know a little bit about AA, one of the slogans is one drink is too much and 1,000 drinks is never enough. And so AA, the whole program is sort of based on a little bit of this concept, is that if a patient ever has a return to alcohol use, there's a significant risk that they're going to go back to their normal patterns. Okay, the second part of the Sinclair method is this pharmacological extinction. So this is really interesting to me. So pharmacological extinction is sort of based on Pavlov's famous work on how behaviors are both learned and then extinguished. And so everybody's probably familiar with the study on the dogs, where Pavlov would ring the bell and bring the food, and the dogs would begin to salivate prior to eating. And so eventually he would just ring the bell and not even bring the food, and the dogs would sort of get ready to eat, right? Well, the same behavior could be extinguished in the animals if they would repeatedly ring the bell but not bring the food. And then over a period of time, the dogs would actually go back to a normal state where they would not salivate in that situation. So this is where Sinclair, when he was doing all of his research, sort of gets all of the credit, because what he did was he would introduce the opiate blocker. He used different ones, but we're talking about naltrexone. And he would introduce it prior to drinking alcohol. And we talked about alcohol having this sort of morphine-like component and endorphins that reinforce the behavior. I sort of included that in the slide again on the left here. And he did multiple studies on animals before human studies were done. But essentially, alcohol use was cut back on drinking when the opiate agonist was given prior to it, because it would block both the opiate receptors and the endorphin response. Another interesting story that the book talks about in terms of pharmacological extinction is this story about this professor who was teaching his students about extinguishing and learning behaviors. And so this professor, he was at the University of Cincinnati, he was teaching his students about this, and the students wanted to test this theory about extinguishing and learning behaviors. And so what they did was during a course of an hour lecture, the students, every time that the professor would move to the left of the room, physically move to the left of the room, they would sort of look up at him and make eye contact and act like they were like super interested in the topic that he was giving. And the story goes that over the course of about 30 minutes during this presentation, the professor was like all the way over at the very left side of the room. He was almost like sitting in a windowsill. And so they had like effectively moved him across the room just by reinforcing positive behavior. And then over the last 30 minutes, they sort of stopped doing that. And then he returned to sort of the middle of the classroom. So after the class, the students sort of brought it up to his attention, like what was going on. And the professor says that he remembered being in the left side of the room, but he just really thought that the students were interested in his topic, but did not realize sort of what was happening in the moment. And so the whole point of me telling this story is that reinforcement has sort of this powerful effect in people's behavior at a non-conscious or subconscious level. And the theory, again, is this extinction can also have powerful effects in changing behavior at a subconscious level as well. The third part of the treatment is this pharmacologically enhanced learning. So when patients begin to get control of their alcohol use, they are not taking naltrexone on days when they are not drinking. And so during those days when patients are not drinking, we try to encourage them to have activities that reinforce sort of the opiate system. So sometimes it's helpful for patients to make a list of things they enjoy doing: sex, exercise, hobbies, engaging children or grandchildren, maybe eating a special meal. Again, these are done on the days when patients get control of not drinking, and this helps reinforce sort of good behavior. All right, this is just the abstract from the Combine study, which I sort of mentioned earlier on. What this study was trying to do is see alcohol dependence treatment, medications versus behavior therapies, or both, and how combining these treatments may impact the effectiveness of helping patients with alcohol use disorder. Again, it was a randomized study, 1,300, I think 1,300 abstinent volunteers originally were in this study. You can look the study up yourself if you want. But one of the main things that came out of this was that patients that were receiving medication management with naltrexone, cognitive behavioral therapy, or both, did better on their drinking outcomes, where the other medication they were looking at was the acamprosate, which we talked about. The real takeaway from this study was that no combo products, so medication with cognitive behavioral therapy, got a better result than just the medication of naltrexone alone. And so back in 2006, when this study came out, a lot of people were not prescribing naltrexone for alcohol use disorder because it sort of had to be associated with like a treatment program where there was like counseling and other services available. And the reason this study was so important because it said like, hey, you can actually just prescribe this medication to people and people will get better whether or not they're attending meetings and going to counseling and things like that. So that was one of the reasons this was a really helpful study. So here's the benefits of the Sinclair method, in my opinion, and some of these things come from the book. The most helpful thing for me is the self-detox component of the Sinclair method. So when patients take the naltrexone an hour before they drink, what happens is they gradually reduce how much alcohol they're drinking. This gives the body time to make the adaptations that we talked about, sort of the neuroadaptations, to go back to a normal homeostasis. And so patients can very easily detox themselves off of alcohol by slowly drinking less alcohol. And the cool thing about it is when patients describe what this is like, it's really like they're not trying to drink less. It's just that they are less interested in drinking, and they realize over time that they're drinking less. So the self-detox, especially from an outpatient treatment or primary care treatment, is super helpful if you have someone who's struggling with alcohol use disorders. Again, similarly, patients can continue to drink while they get better. And again, in fact, the way that the naltrexone works with the Sinclair method is that patients actually have to continue to drink alcohol. Now, naltrexone can be given as a once-a-day dose when patients are trying to be abstinent, and there's some data that that is helpful as well. But again, the Sinclair method must continue to drink alcohol with it. Again, it's a safe, effective treatment in an outpatient setting, regardless of someone's ability to be involved in other activities like meetings or counseling. And it also can be used in patients without alcohol use disorder, but who want to cut down on their alcohol use or control their alcohol use. So we were out in Kearney for one of the, I think it was the nurse practitioner or the PA conference, and we had the Project Echo booth, and so we were just talking to people as they came up, and one lady came up to me and was just like, "Hey, do you guys treat alcohol use? Have you heard about the Sinclair method? Yada yada yada." And I was like, "Oh yeah, I've actually heard about that. I'm kind of more interested in it." She said, "Hey, I was drinking, I was drinking wine. I'm a mom. I got little kids. My drinking was like never out of control, but it was always on my mind. I was always thinking like, okay, when can I have a drink at the end of the day? Or, I would look forward to that drinking time that I would have. I would always try to like keep it, under a bottle or something like that. But it was sort of controlling the thoughts in my life." And she said she went and got a prescription for the naltrexone, started taking it. And again, she wasn't drinking every day. So she was like maybe using this, 2 to 3 times a week. But again, over the course of time, began to cut back on the desires, lower this sort of reward circuitry in her brain. And now she's like, "Hey, I can still have a drink if I want to or choose to. I just take my naltrexone beforehand, but it's no longer sort of controlling my life in a way where I'm thinking about it all the time or I always want to have alcohol." And so I just thought that was a really cool story. And again, this is something like if you see a patient in your clinic that's just saying, "Hey, they maybe don't qualify for alcohol use disorder, but they just are struggling with alcohol use or they got a family history of it and they're scared of it," this medication can be prescribed. And again, they're only taking it on days when they're drinking. Um, Again, so it can be used with patients without alcohol use disorder. I just talked about that a lot. And then again, it's a safe and well-tolerated medication, generally with pretty minimal side effects. Okay, contraindications with the Sinclair method. Number one, pregnancy. Again, you should not drink while pregnant, should not take naltrexone while pregnant. Cannot use the Sinclair method for patients with opiate use disorder because this will cause precipitated withdrawals. This should not be used for patients who have alcohol use disorder and are currently abstinent. So this would only be recommended if there was a return or relapse on alcohol. Again, you can look at studies across the board, but the success rate for abstinence-based treatment programs, 80 to 85%, maybe a little bit better than that. But I just, if I see a patient who's not drinking, I want to at least educate them on this. I'm not going to encourage them to go back to drinking to accomplish the Sinclair method, but I do want them to know that this is available if they have a return to use. And again, when you see patients, a lot of times they've like been through all the things. They've been to treatment multiple times. They've been dealing with this for 20 years. So I do want them to be available, have this available to them. And then the third one is acute hepatitis or acute liver failure. I'm going to talk more about sort of the recommendations around underlying liver disease with the naltrexone here. So when the book came out, the recommendations at that time was that you monitor LFTs, that you would get LFTs prior to initiating the Sinclair method. The package insert for naltrexone does say that it could cause liver damage. Most of the studies that were done that were associated with that were at much higher doses than the 50 milligrams per day. Current guidelines from the PCSS says that you do not have to do that. Essentially, this study looked at a bunch of different studies related to naltrexone or long-acting Vivitrol and liver function tests, and it sought to find out like how should I monitor liver function tests with alcohol or opiate use disorder, and what do I do if there's severe elevations of these tests or acute hepatitis. The body of research, sort of the highlight coming out of it at the Summit of Non-Agonist Treatment held by SAMHSA, it says that there is ample evidence to support that obtaining LFTs prior to initiating of extended release naltrexone is not warranted, nor is routine monitoring of LFTs warranted. And so we should try to figure out if patients have underlying HIV or hepatitis C and sort of monitor those. But the main takeaway from this is, in the way that I'm currently practicing, is I do try to get LFTs if I'm able to. But patients essentially can take the naltrexone as long as they're not having physical signs of liver failure. So nausea, abdominal pain, vomiting, fever, dark clay-colored stools, jaundice. Essentially, the thought here is that like the benefit of starting patient on the naltrexone and not initiating them on the medication while waiting for liver function tests is much more beneficial. And so again, I did include, if you get the copy of this PowerPoint, there's a link to the PCSS liver safety guidelines so that those are available to you. But again, just want you to know that like this is a safe medication that you can start people on. Obviously, understanding that like people who are drinking a ton have bad liver function tests, especially if you look at them over a period of time. And we're going to go and do some actual case studies at the end in 3 or 4 weeks here. We'll go back and do some case studies on alcohol use disorder. I'll show you some actual data on this. But again, generally safe. All right, so leave a few minutes for questions here, but what are the concerns about the Sinclair method? The main concern that I see and that I come across talking to patients, talking to family members, is that the Sinclair method is based on continuing to drink alcohol. And this is a very difficult concept for patients to grasp and family members to grasp, especially if a family member is finally sort of getting somebody in to get treatment for alcohol use. Again, I like to be able to present all the options that are available to patients of what they have for treating alcohol use disorder, but I do want them to be aware that like a lot of times the way this conversation goes is, and I sort of mentioned this before, I'm just thinking of a patient I recently saw, 20-year history of alcohol use, comes in, doesn't have time to go to detox, doesn't have time to go inpatient, is sort of like getting to the point where he gets sick and doesn't drink, and then like has had some seizures. But when I tell someone like, hey, this is going to take 4 to 6 months, and you're going to have to take the medication and continue to drink, that's still just a difficult concept for them to grasp. And so I think there's probably some questions around that, but that's one of the difficult things. The other interesting thing I thought I should just mention is that there's currently a shortage of naltrexone nationwide. I actually just got an email from a patient that I'm treating in Washington who has looked at like 4 or 5 different pharmacies, and none of them can get naltrexone in right now, not until like August. So I have not seen that as evident here in the Midwest, but there is a shortage, and there's a little link to the to that where that's at right now. All right, so to close up my time here, this is the book. It's The Cure for Alcoholism. I hope I've just like whetted your appetite to at least maybe read the book or look into this more for yourself. Again, to be able to offer your patients both with an alcohol use disorder, actively drinking, or people who are just struggling with it. So I'm going to open it up to any questions at this point, and we can kind of have a discussion about it.
So there is a question in the chat from Michael. He says, I have a patient with ALT and AST initially in the 300 range, now down to 100 range. No other source than alcohol. Can I use naltrexone?
Read it to me one more time, Will.
Patient with ALT and AST ranges initially in the 300 range, now down to 100, caused by alcohol, and he's wondering if he can use naltrexone. Yeah, again, I would say 100% use the naltrexone, as long as they're not having physical signs of liver failure. And again, if you want more data on that, get the PowerPoint and read over those PCSS guidelines. But essentially, you're generally, when patients begin to drink less, their liver function tests are going to get much better. And so those risks that were associated with the naltrexone have really sort of been debunked in terms of how much damage that can cause. Obviously, as healthcare providers, we're trying to say, hey, we're trying to do no harm, right? But like the harm of ongoing alcohol use versus naltrexone is generally the alcohol is going to always make that a lot worse. So yeah, great question. A couple more questions in the chat. Next one from Michael. Is naltrexone expensive and is it often covered by insurance?
Yeah, that's a great question. Naltrexone has been around forever. It's a generic medication. It's super duper cheap. Um, I I've always found it covered by insurances, but even if it's not, it's like one of the really inexpensive medications, at least from my experience. So yeah, great question. If you can find it.
The question from Matt about the dosage. He asked if you start right at the 50 milligram dose.
Yeah, so that's a really good question. I should have covered that. Sometimes I will tell patients to start with 25 milligrams for the first 3 or 4 days. So just cut the tablet in half and then increase it to 50 milligrams. You can actually go up to doses of 100 milligrams on this as well for patients. And sometimes they need a little bit higher dose. Honestly, I've used 100 milligrams more for patients that are actually abstinent from alcohol, not doing the Sinclair method. But I think theoretically you could do that. Common side effects of the naltrexone that are explained by patients is generally that they feel sort of sleepy on the medication, maybe a little bit nauseated. So if patients are not doing the Sinclair method, sometimes I'll have them take the medication at night. But yeah, oftentimes I will start with a half, like a 25 milligram for the first 3 or 4 days when they're doing it, and then go ahead and increase to the 50 milligrams. And patients, again, generally tolerate the medication really well.
Here's a question from Scott. A bit off topic. Have you heard any data on efficacy of GLP-1 agonists? For example, semaglutide for alcohol use disorder.
Is this the weight loss drugs? Is that what we're talking about here? Yeah, so this is an interesting conversation. I went and talked to my doctor the other day because I wanted to ask him, like, hey, has he ever heard of the Sinclair method? And what does he know about it? And is he using it? So I had this conversation with him, and he told me a story about one of his patients who was on one of the GLP-1 agonists, who started on the medication, came back to him and said, I don't know what that stuff is you gave me, but I don't want to drink anymore. He was like a guy that was drinking like 20 drinks a day when he would, not 20 drinks a day, 20 drinks when he would go out and party. He always had a drink in his hand, got started on that medication and stopped drinking. So I don't know of the actual research on it, but I have heard about it that there are patients who have significantly cut back on their alcohol use with some of the weight loss drugs.
There's something, I'm no expert, but there's something about the semaglutide or the GLP-1s speed up the pathway to break down alcohol. So I think they break it down more quickly, maybe metabolize it more quickly. I don't really understand either.
One of the thoughts with it, and it actually produced positive results, at least from the rodent side. They haven't really done any of the studies actually in the human population, but with GLP-1 agonists, I mean, it increases the release of insulin and the feeling of fullness. And so the idea behind it is you'll feel full, and then you won't, consume alcohol same way that you won't have an appetite for eating. So at least on the rodent side, it had positive effects as a potential treatment for alcohol use. So sorry, Jeanette, I just wanted to add.
Excellent.
Yeah, thank you.
There's a couple other things we need to make sure that everybody's aware of today. First off, most alcohol use disorder is not chronic and relapsing. And so when you think about people that have, that it can be a time-limited sort of thing. So when you think about using naltrexone, that's a good population to consider. It's those individuals that have the chronic relapsing, more severe, their outcomes are probably not as good on with this Sinclair method. If you look at Howard Moss's data, he describes 5 types of alcohol. And so alcohol use disorder, and those that are the most severe tend to start younger. And it's not the functional or intermediate group but it's the younger or the antisocial group. Those are 2 separate populations he's described. They tend to be the ones that struggle with the Sinclair method because they're more severe and chronic. The other part that's really important that we haven't discussed today are comorbidity. Comorbidity has a big effect on outcomes for substance use disorders. So if you have somebody that has a fairly significant kind of comorbid psychiatric problem like severe PTSD or so on, you have to really look at making sure you're addressing the comorbid problem or your outcomes are not as good. The other thing with the shortage is there's no reason nalmefene, which is an opioid antagonist, won't work as well as naltrexone. They use it in Europe. It's available. It's another option. The other thing, and the final comment, for those of you that may or may not have heard, besides the glucagon-like peptide receptor agonist, is the data that's come out starting in 2007 by a guy by the name of Johnson, 2003, repeated in 2007. The VA has now, because of some of their studies and Morley's work, Topamax is first line for them. And the outcomes for reduction in drinking are greater than naltrexone in some of their data. And so there's a recent study that's come out that it gives you another option, right? So it amplifies the Sinclair method. The big side effects with Topamax, we used to think of metabolic acidosis and cognitive impairment. In this study, it was reduced appetite, which may or may not be a bad thing, and then paresthesia. So Topamax or topiramate may be another option. The whole point of the Sinclair, in my mind, and it's been around for a long period of time, is the echoes open up the windows to look at substance use disorder and treatment options for them, regardless of whether you're thinking about naltrexone or nalmefene or Topamax, or even emerging data on the glucagon-like peptide-1 agonists. And so I think it's a very worthy topic when often we just say, there's no options and just kind of suck it up. Remember, the psychosocial treatments are very important, though, in this, and treatment of comorbid problems if you want to influence outcomes, because comorbid psychiatric problems have a profound effect if they're untreated on outcomes for any of the substance use disorders.
Thanks, Todd. There is another question in the chat from Kevin asking, for patients that will be using the Sinclair method, what type of support group can they use? I would assume it would be difficult to attend AA given the different strategy of absolute abstinence. So any psychosocial supports for them?
Yeah, that's a good question. It is not going to be well accepted in the AA group. Obviously, that's sort of counterintuitive to what they're proposing and what has been helpful for them. So again, AA has been around for a long time, and it's super helpful for individuals. They may find more success in like an NA type of meeting, because sometimes the NA meetings will be more kind to medications that are being used. Also, I would maybe even consider maybe some online options as well, but it can be difficult for them to find some support groups. The Sinclair method is sort of getting more and more attention in different pockets. And so there may be where people can get onto sort of online support groups as well that are more specific to alcohol and Sinclair. That may be something that they could look into, but that's absolutely right. The AA world is not going to be kind to individuals in this situation.
Looks like we're about the end of our hour here. Thanks for the great presentation, Ed. There's a link in the chat. If you want to hop on that link, you can grab your certificate now. I'll also be sending out an email here in probably a couple of hours. Again, just do the quick survey and you will get your certificate. And then we hope to see y'all back here in 2 weeks. Gail's doing a talk on cannabis use disorders. Thanks, everybody.
Good job, Ed.
Thank you. Thanks, guys.
Thanks, Ed.
Great job, Ed. That was fun.
Thanks.
Thank you. It was great.
You're welcome. Thanks.